Now we'll shift into our next segment, the former CMMI Director panel. To guide the conversation along and bring in his perspectives from across the group, I'm pleased to welcome Dr. Mark McClellan, who will be leading the discussion today. Mark, over to you.
Thank you, Judy. It's been great working with you on these Healthcare Payment Learning and Action Network efforts. And I want to thank everyone else who's joining us today. I see many people online with us who have been working hard on these issues for some time. Hopefully some new participants who are interested in joining. This is a great event for all of you and a special one for us. This is the 10th anniversary, and I'm glad to be joined by three former CMMI directors who span most of that time of the LAN to share their insights, reflections, and outlook for the future of value-based care and the priorities for public-private collaboration to support it. Just a little bit more introduction of me for those who I don't know. I'm Mark McClellan, the director of the Duke Margolis Institute for Health Policy and a CMS alum myself. Now, for the next 40 minutes or so, we've set aside some time for a discussion with three people who I think are perfect for the issues of challenges and opportunities and innovation to advance value-based care and accountable care and the payment reforms to support it, as well as perspectives on the Innovation Center and the work that the LAN has done. I'd like to start by introducing Dr. Liz Fowler, who's a nationally recognized federal health policy expert and distinguished scholar at the Johns Hopkins Bloomberg School of Public Health and Carey Business School. Most recently, she served for almost 4 years as deputy administrator and director of the CMS Innovation Center. Liz has also held senior roles at the Commonwealth Fund, Johnson & Johnson, and the National Economic Council, and on the Senate Finance Committee, where she was instrumental in enacting the Medicare Modernization Act. She's a fellow at the Aspen Health Innovators Fellowship and an elected member of the National Academy of Medicine. She holds a JD as well as a PhD from Johns Hopkins. Liz, thanks for being here and bringing your breadth of experience. Next, I'd like to welcome Adam Boehler. Adam also has 2 decades plus of experience in entrepreneurship and healthcare innovation, spanning both the private sector and high-level government roles. He's founded 3 healthcare companies, including Landmark Health and others, before serving as director of the CMS Innovation Center in the previous Trump administration. Adam also served as the first CEO of the International Development Finance Corporation, as a key negotiator in the Abraham Accords, and for Israeli hostages more recently. Thanks for all the public service. I know you're now leading Rubicon Founders, where you're continuing to drive transformational reforms in the way people receive care. And finally, I'd also like to welcome Dr. Patrick Conway, who is currently the Chief Executive Officer of Optum, where he leads efforts to advance value-based care and align payments and support for providers with getting better health and lower costs for their patients. Since he joined Optum in 2020, he's held several leadership roles, including CEO of Optum Rx Pharmacy Solutions, CEO of Care Solutions. Prior to Optum, Patrick was president and CEO of Blue Cross and Blue Shield of North Carolina, and before that, director of the CMS Innovation Center, where he guided the formation of the Healthcare Payment Learning and Action Network, what we're celebrating 10 years of right now. Dr. Conway remains a practicing pediatric hospitalist, is also a member of the National Academy of Medicine, and a former White House fellow. So, Patrick, I introduced you last. Let me start with you, since you bring kind of a unique bridging perspective, both as a clinical leader, currently as an executive, but also someone who was there at the start when the LAN was just getting going. I'm hoping you could lead into the first topic that I'd like to discuss with all three of you, which is looking back on your tenure at the Innovation Center. What models, policy solutions, moments, innovations had the biggest impact, you think, on the approaches that you took at CMS and implications for the future of value-based care, and talk a little bit about why, and then we're going to try and connect that to where we are today and where we're going.
Yeah. So first, thank you, Mark, and thanks for the panelists. I remember when the LAN was on a PowerPoint slide, and then it came into being, and now it's 10 years later. And Mark, thanks for your leadership and so many others, and Andy, I see, and then my fellow CMMI directors. Had the joy to be at CMMI for 5+ years, and just amazing team at that period of time. On your and glad some things in government you start and they just go away. Some things you start and they keep going. So this is in the latter category, and that's great. And I think it's had a big impact, as you heard, in terms of the framework still exists, public-private partnership, et cetera. So all positive. If I look back at the 10-year, I'd call out a couple things. One, we set a goal in 2013 where we had essentially 0% of Medicare payments and true value-based payment models, total cost of care, quality experience, to get to over 30% by 2017 at that time. We actually reached it in 2016, so a year ahead of schedule. I had the pleasure to serve CMMI both in Democratic and public administrations. That was Obama who set that goal and then celebrated it. And the others may talk about this. I think you've seen a progression over time that's been terrific. Two, Pioneer ACO, which was one of those early models, actually got certified. I think it helped shape the future of MSSP and the ACO program in terms of it being scaled, which we may come back to, into the Medicare program, which is the goal, to shift Medicare and Medicaid for the long term in terms of value-based care. Three, and people may not know this, there was a lot of debate initially. Could CMMI do mandatory models? It took us literally a couple of years to clear that goal, and we did a mandatory hip and knee model, if you remember that, a bundled payment model, which did work. But I think maybe even more importantly, it opened the aperture to mandatory models, where I do think we need more of those going forward now that we're at this transition point, if you will. And then the last thing I call out is just setting up the structure in the team, and I called Adam to try to recruit him. I basically pitched everybody with, we're not going to pay you that well, and you're going to work really hard, but you get to change healthcare in America. And we built the whole CMMI team and structure, much of which still exists today. Not all the same people, but some of the same people, and the structure very similar. And talent and people are always kind of the ball game, and I think we set a foundation that the other panelists continued to really have a talented team at CMMI that partners with the private sector and drives results.
Well, Patrick, thanks for that overview. A lot of history there, and a great lead into Adam. So do you remember that pitch from Patrick?
It's so compelling, right, Mark? Everybody on this screen has heard that pitch and somehow takes it one way or the other. So you got
and
to
they should keep doing
everything we
too.
say in that context.
Well, so you came in after these initial goals, the framework was in place, and Adam, you had some bold ideas about moving forward, including some things that I recall resonated with some of the topics Patrick was just talking about: bolder models, moving out of just a little bit of upside risk only, things like that.
Yeah, I mean, I think, and this is, I'm just going to comment a bit on the tradition of CMMI, because when I took the role, Andy and Patrick said, how is CMMI not just dependent on a really great director? And the quick answer is, I don't know, but we have been blessed with really great directors. And the reason I say it is because my view of my job coming in was what the mission of the organization is, which is to lower cost and improve quality for Americans. That's it, simply, right? And by changing incentives, that's how you do it. And the unbelievable thing about that is, in theory, that's not any partisan idea, right? It's an American idea, and that's why consistently you see people working. Now, the amazing thing then is how you have I was able to build and listen to the prior administration. And so normally what happens, and this is what happened, you come in and you review what's prior. So sometimes it takes a little while. There's a bit of a hold, new people come in. And then what I found from being in administration is where things are good policy, where they do what they are supposed to do, and they're doing the right thing, then the next people keep it and build on it. It's not destroyed. And that creates continuity over multiple administrations because it's serving the goals of each one of those presidents. And so in my case, we looked at it. We looked and we said, listen, does this serve President Trump's goal of lowering healthcare costs for Americans? And it clearly did and does. And so what we're able to do is say, okay, let's take on that bill. Let's see what worked, what didn't work, what we should do. And so if I sometimes think in terms of themes. And so I think themes, when Patrick started this and when he drove it, is kind of let a lot of flowers rise, a million flowers, whatever that, whatever people say, and then see what works. And what was clear that worked was upside risk is good, but with downside risk, holding people accountable, making sure there's models for everybody if they want to participate. Not just a big health system, not just a single doctor, but across if they seriously want to do it. Ending just optionality, where it's only upside one or the other. So those were some things. And the reason we identified those was we actually looked at, hey, what from a cost perspective, where do things work to achieve lower cost and improve quality? And then we built on that and really streamlined. We also heard certain things. They said, look, at CMMI, don't make it too complicated, okay? You've got to refine. So then we started to say, okay, let's start with big swaths. We started primary care. Let's show specialty, or let's start with kidney care. And then let's prove this out, and let's try to set it in a way where I use this term a lot, and there's a common chassis across, which is, hey, this is simple. People can understand it. And if it works, you can start to leverage it out. And then the final thing is make sure that people understand it. And I still think, and this group does, and I give thoughts to the current CMMI leadership is, how can we take things like savings and share them with individuals that are involved in the models, because that will capture American attention. Because the really unbelievable thing about value-based care is it continues to progress every year. It continues to save money in each administration. It expands and it lowers costs. It just doesn't get good billing because people don't understand. But if we can really show to Americans, not only is it lowering your cost of care, but it's lowering your cost today, this year. And I think, and we'll talk about it, some of the innovations that you see in this administration to build on. And by the way, Liz did exactly what I did, which is come in, investigate, build, hire, commit. And now, as you see, Abe, they're starting to say, wait a minute, could you use some of these things in the next ACO models to waive supplementary cost, to waive some of these things? That's really huge, because an American in an ACO model will see that and feel that even that day. So it's sharing now direct. So I'm excited. It's something that Patrick, me, Liz, others have thought about, and I think it's taking to the next level.
Well, a lot to follow up on there too, but first, Liz, bring us a little bit closer to the present. So you came in and I think did the same thing when you started in 2021. It's a bit different world then. We're in the midst of a pandemic, but a lot that you built on as well.
Yeah, thanks. And I'm so happy to be here and see my colleagues, and also just to hear the remarks of the current leadership at CMS and CMMI, which is so consistent with anything that any of us would have said at any point in time. And I think that gets to the point that Adam and Patrick are making, that this is a tradition of alignment and continuity across administration, and that really warms my heart that that's still the case. And also just thanks to and congratulations to the LAN on the 10-year anniversary. That's quite an accomplishment. I think the LAN really plays an important role for CMMI to hear from stakeholders across the healthcare system and hear from them what's working, what they want to see, what they don't want to see. So I feel like my job in some ways was easy taking the reins, in that there was already a strong, solid foundation of good work that was happening. But I also think there were challenges, and the job keeps getting harder because the expectations are higher. Why hasn't more happened? Why aren't there more savings? Why aren't we seeing, more of the healthcare system moving towards value? So I think the bar gets higher, but I think the team continues to be innovative. The leadership continues to be innovative. The new strategy and the direction the current administration has taken things, I think, is very much in line with where we were heading. So it feels like we're building on what we've learned, and hopefully narrowing in on a set of priorities and policies that can be sustained. I think we need to really focus on what can be sustained over the long run. So not just a model, but what are we going to see in the healthcare system as a whole? We need to move away from just testing models and building on what works. And I think that's going to be, that's probably one of Abe's charge. And I think that's probably what the next director is also going to be charged with.
Yeah, and I know we heard from Abe is with the government shutdown, not present today, but you heard his highlighting of the initiatives now at the Innovation Center, which, Liz, I think includes building on some of your models. There's a question in the chat about the gene therapy model, so paying based on outcomes for transformative therapies, your multi-state model, the AHEAD model, moving that forward with an emphasis on moving to whole person, total cost of care, payment systems and supports across all payers in states, the REACH model now with the evolution towards the new model called LEAD. But it seemed like some new steps as well, if I was just reading in. And I'd like you all to turn now to where we are today and what you're concerned about going forward. Liz, you mentioned that as time has gone on, the expectations have gotten higher, but this is still hard. I think that's something that people kind of found along the way, and just translating a couple of Dr. Oz's opening comments, he talked about the importance of getting to better outcomes and paying for value. And I hear that all the time from the current CMS leadership, just like I did from each of you. But then Dr. Oz went straight to things like improving our data infrastructure, getting Medicare data shared in real time, working with other parts of the healthcare system to bring down administrative burdens, and in particular administrative burdens for going to value-based care. Maybe hear them talk a lot about making this work more easily for smaller providers who haven't participated as much, and trying to encourage more competition and choice, as Abe mentioned as well. So it suggests that payment's really important, and that's in the name of the LAN. But it also has these other things that go along with it: payment plus, reducing burdens, making other key aspects easier. So let me ask you all, what would you like to highlight in terms of where we are now and overcoming some of the challenges in making continued progress in value-based care? And it does seem like public-private collaboration is an important part of that. Liz, you mind if I start with you this time?
Yeah, sure. And look, I think, in addition to we need to figure out how to scale what's working, I think that data infrastructure is really important, as well as the reducing administrative burdens. But what's exciting is you're now getting to the sort of second and third level issues. So we know sort of generally what's worked and what's working. We need a strong primary care infrastructure. We need data. We need a team-based approach. We need aligned payment incentives. I think I agree very much with Adam that we need downside risk. That's got to be part of it. And now we're getting to those, okay, like what do we need to do from an operational perspective to make sure that being in value-based care is second nature and not something that takes a lot of time and effort, and that is a high hurdle for those who want to jump in. So are there enough pathways for people to jump in? Can they be successful? Do they have the tools and the infrastructure that they need to join? And I think all of those elements are exactly what is needed. So I'm really happy that the administration is focusing on that administrative burden piece. Also really excited that they're leaning more heavily into the digital strategies and thinking about how we can bring more sort of technology-enabled approaches into models and make sure beneficiaries are able to have access to some of those tools.
Yeah, and I know it's maybe a plug for you. You and Perver Wall wrote a couple of papers that were out last week on some of the steps, in conjunction with moving toward downside payments and the like. One of those was about things like how do you set benchmarks in a way that helps encourage sharing the savings back with the providers and the beneficiaries who are taking up these new models. Another thing that's changed since you all we're moving these models forward is that we have a lot more people in value-based care. Majority of the Medicare Advantage, a majority of the Medicare population is in Medicare Advantage, and majority of those plans are using alternative payment models. Growing share, close to 50%, I think, in traditional Medicare. More downside risk in all of those, but we're still kind of basing everything off of the traditional Medicare program. And you had some thoughts about that this past week. I don't know if you want to make any comments along these areas where you're spending a lot of time now.
Yeah, and that article in Health Affairs was really focused on what do we need to do to enhance the foundation we've already built in accountable care. And so what makes accountable care work? We know those elements: team-based care, person-centered approach that relies on a strong primary care framework, as I said, the data that enables the risk stratification, care coordination, earlier intervention, aligned financial incentives. But there's signs of strains in sort of moving towards more accountable care. Some of the financial unpredictability, maybe the incentives aren't strong enough. The operational challenges and program complexity, which gets at the point you made about reducing administrative burdens. Some of the barriers to greater beneficiary engagement and the lack of financial tools to provide some of the enhanced benefits relative to Medicare Advantage, like Adam mentioned. Like, couldn't we get more in the hands of people, in the hands of patients? And I mean, another one, just throwing it out there, is that sometimes fee for service payment changes in the traditional Medicare program can undermine ACO participation incentives, and I think we need to be mindful of that. And so the paper really was trying to lay out a series of reforms that could strengthen accountable care. Refer everyone to read it, but you mentioned benchmark. I think we need to make sure that we avoid that ratcheting effect. So how do we bring in participants who haven't joined to this date? And so there's some ideas for that. How do we think about global risk arrangements? We need more opportunities for global risk arrangements. Look, I think these are two areas that I expect or anticipate will be addressed by the LEAD model. And then also thinking about how do we increase and enhance integration with community-based providers. I know we don't use the word equity anymore. Equity and trying to address some of the disparities in healthcare was one of the big themes. If you really want to reach hard to reach underserved populations, you really need to be connecting with those community-based providers. Call it whatever label you want, but it's still really important to make sure that we're reaching all beneficiaries and give them all a chance to benefit from value-based care.
Great. Thanks, Liz. And Adam, your current day job is pretty much building companies that do what Liz just said, right? That are using advancing coordination, smart targeted intervention, digital AI enabled services, beneficiary engagement and empowerment in the community, all supported by more global risk, not fee for service. Could you maybe talk about how things are looking from your side of things and the private innovator community and how that relates to where we go from here?
It's a very interesting time in the healthcare community broadly. And this goes to, what happened last week with Medicare Advantage payments. And I'm going to give a counterintuitive view, which is that, and you may have noticed on Monday, $100 billion of market cap was wiped out. But I want to be clear from my perspective, which is I think the administration did exactly the right thing. And I think they did because they're evening the playing field and doing it in a fell swoop. I think there's always been a difference or question around Medicare Advantage versus fee for service. This will allow Medicare Advantage plans to price that in when they do rates and address it so it's on an even playing field. And we never get to the point where there's any question when people are choosing Medicare Advantage that it's chosen and it's on the same playing field, and they're doing it quickly, thoughtfully. I'm sure they'll take industry feedback to adjust in certain areas to make sure there's not bad consequences. But I view it as positive, actually. And I know that's counterintuitive because I know there's a lot of plans that were upset. The other thing that it made clear is that the administration is neither pro or a shill for MA, nor pro or a shill for fee for service. They're doing their job, and their job is to lower costs and improve quality to create competition and choice. And so if a patient chooses fee for service or chooses MA, the administration's role is to make sure they're informed and to make sure that they're supported in their choice. And that is ultimately what they need to do while making sure that things are competitive. And so I think they made exactly the right move. So for us, what do I think about? I think about why we're involved in value-based care in the first place. Why? What does it mean? Again, it means lower cost, improved quality. As long as you're betting on that side of things, eventually you're always going to be right. And I think the threat, or what we think of difficulties to value-based care, are the things that are going to be addressed over time, which is you see LEAD coming in with a 10-year model. Why? Because people were saying value-based care was dead. Well, if value-based care is dead, then it goes to fee-for-service completely, and prices just keep coming up. And so the administration answered definitively that value-based care wasn't dead. And in fact, they learned, Liz, from what you had approached and said, hey, let's give a longer time period so people can invest and predict. That was a very, very important sign from LEAD and what they intend to do, what they said in the webinar. So I think that type of consistency and commitment is very, very important, and it builds on everything we did. The other thing I'm aware of is the alternative. And so the closest thing I look at is where are there massive margins in healthcare? The administration, both administrations, by the way, have been addressing drug costs in the United States. And I will say, I saw in a Wall Street Journal article just last week that this is the first time since people started tracking the index, so ever, that drug pricing went down. It's the first time. And that is a whole variety of factors. But I will tell you something. It's because of unified view that the United States is paying too much for drugs and that other countries need to step up one or the other. And so there was movement there. I'll tell you where the other heavy margins are in healthcare, in dominant systems that are fee for service. Nowhere else will you see 5 to 20% EBITDA margins, but in dominant systems. And so I think for those folks, I think people need to know, and they need to see the signal that it's not okay to just stay the same anymore, or they won't justify their $50 million salaries in a nonprofit health system. So these are the kind of things that are uncomfortable to say, but the administration knows. And so when we're thinking about margin, this is where it will condense. Let's take that margin condensement and let's put it into patients to get more services, to get premium, and not to just do the same thing with market dominance. And that is something I will tell you, all of us know, and all of us are united behind. And I think so much of our job now, as things go forward, whether it's ABE, whether it's whoever comes, is to show that bipartisan support. And I'll make one other comment, which is, Liz, you had a tough job when you started. And you had certain things, but things started to get a little political at times. And there was some push, and I'll tell you, there's a couple folks that know CMMI that wrote something negative about REACH that I thought wasn't true at all. And I reached out and I said, hey, we could work together, and I was pushed away on that. But here's what happened. And this is really important because Liz and a group of folks stopped it from becoming politicized. And what happened was, and Patrick, you were involved in this, a number of folks, Democrats, wrote to the other Democrats, and they said, hold on a second. The purpose of this model is to test. If you end a model before it's successful or doesn't successful, now you've meddled in. And because Democrats told Democrats that, it backed off. But I will tell you something, Republicans saw that and recognize that it is not partisan. And so it could have gotten partisan, but the own party stopped it. And I think that has created a not even partisan, an American support behind it, because we see that everybody's united and it's not that. And that was tested. That was tested. And Liz showed under great pressure, to be clear, that she wasn't going to be moved from any party. She was going to do what was right. And people behind supported her from her own party. And that made a big difference. It shows the example, and everyone saw that.
Liz, I see you nodding. Anything for everybody?
Thanks, Adam. I appreciate that. That was a tough time, and I'm glad we were able to keep the model going, and really did count on a lot of support from folks on this call, actually, and in the leadership. So thank you.
It is interesting to see that continuing bipartisan support and also some bipartisan criticisms, frankly, of this innovation work. And as you all have highlighted, the importance of keeping some consistency and thereby predictability that helps with investment, that helps with confidence about moving forward, and also about that boldness around moving away from fee for service, getting into downside models, and instead of just going slow, focusing on, well, if it's hard, how do we make it work better? Patrick, I know you've done a lot of thinking about all this from all sides now.
Yeah.
Please go ahead with your comments on where to go from here.
Yeah, and I just had a CMS leader call me during the call, so you just keep working. So I'd call out 6 things as we go forward, and multiple of these Adam and Liz hit on. 1, align payment models that are generally two-sided risk, mandatory when needed, and allow participation across the spectrum, including independent physicians and clinicians. So we've seen physician-clinician models often perform on average better than large health system models. Obviously, there's some positive examples in both categories. 2, define the outcome and let the entities innovate. So I think stability and predictability and enough lead time for the private sector to plan and innovate. I think we've seen both positive and negative there. 3, I do think we're in an era of data technology, AI, where rapid cycle change and reducing administrative burdens and AI powering the clinical innovations will bear an acceleration of all these models. So you've set the outcomes, and I think they'll increase the likelihood of success. 4, public-private sector collaboration. So I think whether it's a Maryland model or Pioneer ACO or even diabetes prevention, I think we generally have had more success when the public-private sector came together, and I think Adam, Liz, and the other CMMI directors have continued that. And obviously the Healthcare Payment Learning Action Network is an example. 5, I don't want to lose this, is the importance of scaling the successes into Medicare, Medicaid, and private sector. And I think it's both scaling the model, also scaling learnings within the model. So like collaborative care coding in mental and behavioral health came out of a CMS Innovation Center Award, but then was put in the Medicare program. Obviously the ACO program, everybody on this call continued to evolve it in a positive way. So I think that scaling aspect matters. And the last one, they both know this. I called it like cultural almost, or leadership. Traditional Medicare fee-for-service, you pay claims within 14 days. There's no true efficiency dynamic. And we know when you have accountability for total cost of care, quality, experience, and the right way, you drive better results. It is the pathway to a higher performing health system, which America needs desperately. So how do different administrations set goals, measure success against those goals, and do it with the public and private sector? And I get it. Dr. Oz said this in a dinner with a lot of people, an event, and I came up to him afterwards where he said, I want fee-for-service to go away. Adam, you said it one time in a panel with me. I was like, I said that 10 years ago and I got destroyed. I got skewered. Now it is more reasonable to say, but more importantly, we made a ton of progress. And what I think he meant by that, and what I meant by it, I can only speak for myself when I said it, was you got to have a system that's incentivized around quality, experience, and total cost of care. I mean, it's kind of obvious. And then you iterate on that system, but a system with none of those incentives in place, by definition, will perform worse. So it's cultural leadership.
This has been a great discussion. We have just a few minutes left. I wanted to pick up on one theme, Patrick. Well, all of you mentioned. I think it was number 3 on Patrick's list of 6. I never get a list of less than 6 with Patrick, but it's always a good list. That was digital AI enabling rapid learning and more improvement. And obviously that is top of the priorities, along with crushing fraud for the current administration too. Could you all briefly talk about what you see as the best opportunities there? So the access model and new CMMI, when focusing on apps to beneficiaries in the near term, is a piece of that. But really, I think you all have in mind more technology embedded in care, and there are a couple of comments in the chat about, well, don't you need better, more timely data flows than, Patrick, your 14 days or whatever it's been traditionally to go along with it. But maybe just a few comments on data, technology, AI, and how it can make the next few years of the LAN's public-private collaboration work and CMS's and all of our work easier. What do we need to do?
You want me to go first on that one?
Sure.
Yeah, I'll be brief, and I know a couple of us have the hard stop at 2:55. One, administrative. So, we're doing this through a product called Optum Real, but you could do it all sorts of ways. But how do you actually have in real time, the payer knows what they're going to pay, the provider knows what they're going to be paid, and the consumer knows. We're doing that across payers and systems right now. CMS is trying to do this. I think that there's a huge bucket of administrative savings that I think is very large. 2, I think patient engagement and behavioral change empowered by AI will be differentiated, that it really gets to like personal engagement. How do you help manage that person's life through various chronic conditions and other access to care, et cetera. I think it's going to transform the way we think of it. And then the last area, which, we and most folks, you still want a clinician to make the final decision, but how do you make it much more efficient? The story I tell internally, I'll share with this group. First week as an attending, I get to page 287 of a child that had bounced all around America for 2 years. I'm like, oh my gosh, they have a metabolic disorder. That ended up being what they had, a very rare disorder. In today's world, AI should scan that and queue up the 5 possibilities, including that one, within seconds. And actually, it gets to license issues too, where everybody should be able to be much more effective, from physicians to nurses to medical assistants. So I think in the clinical realm, the sort of effectiveness and efficiency gains we could get are huge.
Great, thanks. Adam, you want to go next?
A lot of what we're looking at is delivery innovation. And so I'll give an example. We have a company that we started, and what it does is it takes full accountability for very complex kids, Medicaid and state. And it's a business called Imagine. And the difference, so I started a business called Landmark. A lot of this we had to do, in a more physical way, but in Imagine's case, what they do, and I'll tell you the value prop is basically you have kids that aren't seen by physicians or the Medicaid system because they have multiple chronic conditions, they have a vent, they're disabled, and these kids end up going to the hospital with their parents sometimes 20, 30, 40 times a year if a feeding tube falls out or gets infected. And our job is to create a whole team-based environment for them so that when it's unnecessary, they don't have to go. And when I look at the amount of interactions, technology, if you're parents with a child that has many complex conditions, you interact with Imagine sometimes hundreds of times a year. They're short, they're over technology. Sometimes you video in when it's necessary. But oftentimes this is about support and having the best people supporting them and having 24/7 access to a pediatric that's focused on pediatric leader that's focused on complex kids anytime, 2 a.m. It doesn't matter because that's inevitably when things happen. And so we are using technology to drive a lot of that. And then we are also able to have technology to say, okay, where are the problems going to be in the future before they come up. We get lots and lots of claims data from our different areas. They're very dense. We get lots of EMR data actually from both the ADT systems of health systems. So we'll know if one of our kids hits an emergency room immediately so that we can help them. And a lot of it is helping them out and making sure they're situated well. And then a lot of it is, okay, where should we be spending our efforts by predicting where it's going to be and making sure that we're there and ready. And so I view that business as totally different from if we had started that business even a few years ago in using technology to drive workflows and clinical outcomes for those patients.
And you really need that all-in payment to help support that. Liz, last thoughts on this important topic?
Thanks. And so I look at what this administration is doing, what Abe and his team are doing, and some of it's like, gosh, I wish we would have thought about that. And one example is the Wiser model, which I know has gotten a little bit of flack. There's a little friction, but let me say
a little bit.
What's that?
A little bit.
Well, let me just say that we tried really hard to think about a way of addressing low value care. Like the team really thought about this, and we knew that it was a problem. It was something we wanted to look at, and I think they came up with a creative solution to try to address low value care using AI and using a way that I hope can circumvent these decisions and make the process more smooth. If anything, it's aimed at trying to rid the system of sort of these costs that maybe shouldn't be in the system and do it quickly so it's not an administrative burden. So again, we tried to find a solution for this particular problem, and they've gone and done it, and really excited to see where that goes. Again, I know it's not everybody's, top of the list favorite thing, but keep in mind, this is the Innovation Center. The Innovation Center is supposed to try new things. That is the whole idea behind the Innovation Center. And Adam, when you spoke about, this long history of directors who take this role, I think one defining feature of people that are in this leadership role and leading the Innovation Center are people that believe in innovation, that come to healthcare and the problems that our system faces with a level of optimism and with a level of like, hey, I think this is a problem we can solve. And I think, and then test it. And the point of testing is you see what works and what doesn't. And so obviously not everything's going to work. And we can have a whole conversation of how you determine what's working and what's not. I think, I have a lot to say on that, but let me just say that that's an area that I'm excited about. And I wish we would have thought about it.
Well, I just add, you all thought about a lot of things, and one area where technology, digital help, and AI should make it easier is doing that testing and evaluation, more sophisticated, faster, more efficient models applied there too. But I really appreciate, Liz, your point, and thanks to all of you for creating this culture and environment, and everybody who's with us, who's willing to be there and try out the new things to help find ways to overcome the payment barriers as well as all these other barriers that we've talked about. I appreciate your leaving this with a positive view. Maybe really quickly, as we just finish up, last word. The LAN is a public-private collaboration, involves the team at CMMI, the Kate Davidson and Mel and Andrea and the Learning and Development group there, Deloitte, collaborators at Duke and elsewhere, and especially all the collaborators on this Zoom who are thinking about what's next. Quick piece of advice, next thing that LAN should be sure to focus on. Patrick, I'll start with you.
Set goals, go faster, innovate.
Very good. Adam.
We need to go faster.
Faster and leverage technology, yeah.
I think on this, what you're hearing in support of what Abe is doing, what Chris is doing, what Oz is doing, across administrations is unique in any area. And so you're hearing bipartisan across the board support for this approach. And from a private market perspective, we need the support there, because I think Abe's goals and CMMI's goals are to do it together. Abe hasn't said, hey, I want to do this separate. If you look at how he's setting things up, for example, how you nest specialties into value-based care. That's very important. It's very important for CMMI to drive, but it's very important to do together. And so the private market has the ability to unite behind, to give suggestions, by the way, how it could shift, et cetera, and then really drive a difference across payer classes.
And its emphasis may seem a bit different, but that broad-based support, which the land can help drive, is really important. Liz, last word.
I mean, look, we've said they need to move fast, which I agree with, and I think that's what the rapid cycle innovation that they're testing through the learning and diffusion center. I think that's really important, but that sort of predictability and stability of the long-term model. So it feels like they're trying to address both challenges all at once and running as fast as they can. And I wish them all the success in the world in doing both things and continuing the great work that's started and hopefully will continue.
Great. I want to thank all of you, Patrick, Adam, Liz, for joining us today, for all you're doing in your current work to continue this broad-based support for the hard but critical work of transforming our healthcare system. Thanks for being with us. It's been a great discussion, and this actually leads right into the next segment of today's 10th anniversary event, where we're going to move from looking at what's happened and what this extraordinary and diverse set of leaders thinks about what is important going forward to what the LAN is actually working on. So with that, I'd like to turn to Dr. Alice Chen to provide some updates on the LAN's current and planned work. Alice?